All right, we're focused on cardio. We are still hanging out with the patient who has acute coronary syndrome. I wanted to bring to your attention an atypical patient this time, because we talked about the typical, right? We talked about the patient coming in with chest pain and their jaw hurts or their shoulder hurts or their arm hurts or their back hurts or whatever hurts, and they're sweating and they're anxious and they're having all kinds of signs of a heart attack, an MI. And we did what? We gave them 325 of aspirin. We went ahead and gave them the EKG within 10 minutes of arrival. We went on ahead and started nitro and titrated it based on the pain scale. We made sure that we weighed the patient so we could be ready to give them heparin and send them to the cath lab. We did all that with the typical patient. We did talk about a little bit of atypical presentation with women and diabetics, and those are all in my other videos. And we talked about the fact that the patient could have one of three situations all up under the umbrella of acute coronary syndrome. We could have an ST elevated MI, traditional MI. We could have unstable angina. That patient's going to get a stress test, not a cardiac cath. We could have a patient that has an NSTEMI, a non-ST elevated MI, blah, 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 right? Now, there was one thing I wanted to bring to your attention because I would be kind of negligent if I didn't. What if your patient's 28? What if your patient's 32? What if they don't have a history of hypertension and atherosclerosis, cardiovascular disease? And what if they weren't shoveling snow? And what if they hadn't just had sex? And what if they hadn't just worked out at the gym? What if there was no death of their mom? What if there wasn't any stressor that you could point to? What if they were, again, atypical? Who are these patients that we see with this issue? And is their issue, like all of the other patients we've been talking about, is their issue an occlusion of the coronary artery in the form of an atherosclerotic plaque? Oh, you forgot? Okay, let me remind you. Sometimes you forget, honey. I know, I get it. It's a long day. Normal artery, right? Normal. Completely opened. I can fit my whole finger inside that artery. It's clean as a whistle, looking good. For our acute coronary artery patient, as they go through the years of bad eating, terrible exercise, well, I shouldn't say terrible exercise, no, terrible activity, right? They're sitting on their butt. Oh, let me call you out. You drove your car across the street for the football party at your neighbor's. Oh yeah. You took the elevator to the second floor. You parked damn near handicap parking to go into the store. You know, the pregnant lady parking, you parked there. Yeah, because you didn't want to walk. Yeah, instead of getting up, getting out, and going to the store or the McDonald's, you now are ordering DoorDash. Yeah, I don't order those things through DoorDash and home delivery. Oh, yeah, I don't do it. No, because I need to get up. I need to move. You know, there used to be a time, I know you can't believe it, but there used to be a time that you got up out of your chair and you walked and you made one foot chase the other and you went to the television and you changed the channel. And then they got remote controls and y'all just towed a club up after that. No, not good, because you're not moving anymore. And when you're not moving, neither is your blood. And blood that sits still clots. And blood that clots occludes, and blood that occludes causes heart attacks, acute coronary syndrome. So again, not much difference between these blood vessels. Little bit though. Look at it closer. There's starting to be some atherosclerotic plaques of calcium, fibrous tissue, and good old plaque. Now, the person that comes in with acute coronary syndrome and does not have a heart attack, but instead has angina, They have not completely, watch this, they have not completely occluded this artery. Nope, there's still a little hole in there. I could stick something through there, but my finger's too fat. So I'll just suffice it to say, I hope you can see that hole. This is angina. This right here, the red has shown up. It's a clot occluding the coronary artery. Acute coronary syndrome, the same thing we've been talking about. But the title of this particular acute coronary syndrome is atypical because your patient's 32. They have not had time to go from here to here to here to here. They have not had that kind of time. So Shelly, what did they do? They didn't have the sedentary lifestyle where you sit on your butt eating bonbons. They didn't have the situation where they were stressed and had a fight with their family. They didn't find out that their precious mother died. They didn't smoke 2 packs a day, or I'm sorry, 10 cigarettes a day. Oh, so they didn't eat donuts and cupcakes and all this crap all day long, like lots of sugar, because sugar is the real enemy here. They weren't a diabetic already. Oh, they didn't have any cardiovascular disease? Well, then what happened to them, Shelly? Well, they was playing in the snow, y'all. Yes, indeed. What is playing in the snow called? Cocaine. Oh, yes. It's cocaine. And what did it do to the patient to cause them to come in with acute coronary syndrome? It vasoconstricted their arteries and caused, more importantly, vasospasms. So vasospasms is a different type of angina. Write this down, you're gonna thank me later. Prinzmetal angina, also called variant angina. This is the type of angina that we very often may see in someone that is using cocaine. Smoking crack, same damn thing, different way to do it. But it's the same thing, you know what I mean. The patient is very atypical. This is a much worse chest pain. We sometimes even see this in women. We see it worse at night. But suffice it to say, instead of an occlusion, or not necessarily an occlusion, but a narrowing of the blood vessels, it's more of a spasming of the blood vessels, okay? And so I did want to point that out. Now, all of these patients are going to be on some type of medication to prevent this from happening again. All of these patients are going to have to completely change their life to survive after this. All of these patients are going to face reality that they're going to have to move more, and they're going to have to really focus on their diet and things that they may have eaten before and never even thought about. Many of these patients, if they've had an actual cardiac event like a heart attack, will have to go to cardiac rehab. They will be told that they should not drive or work for up to a month's worth of time. They can't have intercourse until they can walk up the steps and not be short of breath or dizzy. Their whole life will change. Many of them may have occupations that are incongruent or inconsistent with you just had a heart attack and I don't want you to have another one. Air traffic controller, police officer. They're not going back to those jobs. That would be ridiculous because they're going to have another heart attack. And so when a person has an acute coronary syndrome event of some type, they're going to be on a list of medications. Their lifestyle will change considerably. They will find that they either will change or they'll be back with another heart attack. Are there some people that don't qualify for a cardiac cath? Absolutely. Are there some people that instead of a cardiac cath, we have to do something else for them, more invasive? You bet there is. And those patients usually get what we call a CABG, a coronary artery bypass graft, right? Let's look at that. Coronary artery bypass graft. This traditionally has been patients that have more than one vessel occluded, patients who are diabetics. The coronary artery bypass graft CABG patient traditionally has had open heart surgery where we saw through the sternum, crack your ribs open, stop your heart, put it on a bypass machine, put the patient on a bypass machine that's going to function like a heart, pumping blood and oxygen, and we work on the heart to take another big, large vessel from some part of your body, either your leg or the chest area, mammary vessel, and we literally take that vessel and watch this, because it's actually amazing what doctors can do. And so I've just been infatuated with cardiac all my life. So here we go. We're going to have a blood vessel, and let's, for the sake of this lecture, just occlude the crap out of it, shall we? There we go. The patient coming in with an acute coronary syndrome that has an STEMI, ST elevated MI, has a heart attack, an actual occlusion of the blood vessel. The EKG showed the ST elevation, the blood showed the troponins. Here they are, but for whatever reason, they cannot get a cardiac cath because there's about 4 of these in their body. So if it's 3 of them, it's a triple CABG. If it's 4 of them, it's a quadruple bypass surgery, right? Quad, triple bypass surgery, quad bypass surgery. 3 or 4 vessels occluded, right? So if that's true, we're going to take a whole nother long, strong vessel from your leg, like a saphenous vein, or from your mammary area, chest wall, and we're going to, watch this, we're going to take that brand new, strong vessel and attach it to bypass this blood vessel. Because what you got to remember is, here's the blood. And it wants to get through this occlusion, and it cannot. And what's happening is this part of the heart is going to die. So when you took that big, strong vessel from the leg or the chest wall, and you attached it, and what did you do? Watch my fingers. You bypassed the blockage. Coronary artery bypass graft, because graft means you took a part of some part of your body or another person's body and attached it to your body in a different place. And so now the blood can flow very easily out this vessel. CABG. Oh, don't get it twisted. This is major surgery. It is outrageous, long, major surgery. The patient will be in tremendous amount of pain afterwards. Of course, we're going to manage it, but I'm telling you, when you cracked my ribs and sawed through my sternum and stopped my heart and made me 92 degrees, well, not really, but at least 95 degrees cold so that I required less oxygen, it kind of impacts the patient, right? So they're going to go to ICU, and they're going to be on a lot of pain medication, and they're going to be really encouraged and managed. We're going to have to manage their pain in such a way that they still can cough and deep breathe. Because Lord knows, if you open my chest, saw through my sternum, crack my ribs, stop my heart, doing this or that, is excruciating. So the priority for that nurse is pain management. All right, let's move on.